Committee will come to order. Thank you, everybody, for attending today's hearing entitled Sacred Obligation, Restoring Veteran Trust and Patient Safety. Before we begin, I'd like to ask unanimous consent that all the members whose names are in front of us be allowed to sit at the dais. That would be Lacey Clay, Jerry Costello, Blaine Lukemeyer, Ileana Ross-Layton, John Shimkus, Mike Turner, and Frederica Wilson. Without objection, they will be allowed to participate in today's hearings.
Hold it, I don't know what Ileana.
Okay, Ileana, you have to leave. Hearing no objection, thank you all for joining us for this important hearing. We as a nation put our trust in the men and women who serve in our armed forces to protect us and our freedom. And in return, our service members put their trust in us to provide them with the highest quality health care. However, incident after incident of serious patient safety violations in VA medical facilities across the nations in locations such as Dayton, St. Louis, and Miami, resulting in thousands of veterans across the country receiving notification of their potential risk for infectious diseases like HIV, hepatitis, shatters that very trust that veterans should have in each of us. After each of these incidents, the VA assured Congress and the country that it was aggressively addressing patient safety issues, and never again would a veteran's trust be compromised by lapses in quality care at a VA medical facility. And yet, each patient safety incident has seemingly led the way for the next lessons learned and the unacceptable and inexcusable revelation that the patient safety culture in VA is fractured and accountability and leadership at the helm are lacking. The time for talk is over. VA has got to confront these issues head on, deepen the obligation to care for the veterans affected by these incidents, and make the necessary changes within the VA health care system to prevent any future incidents that would put veteran patients at risk. To that end, at this hearing today, we will address in depth the efficacy of VA's patient safety policies and VA leadership's ability to provide adequate oversight of its medical facilities. And further, we're going to explore the development of proactive strategies for addressing the issues that underlie the lapses we've seen in patient safety, including the need for improvements in reprocessing of reusable medical equipment, systematic ways for VA to limit the activities of suspect practitioners, and better and more consistent or constant risk management and notification processes for veteran patients when incidents do occur. It is unconscionable that any one of our veterans should ever be exposed to infectious diseases because of the care they receive at a VA medical facility. I want to assure all of you that this committee will be tireless in its oversight to ensure that VA lives up to its creed to provide only the very best and the very safest care anywhere. I thank you all for joining us for this ongoing and most important discussion. Before I yield to the ranking member, I'd like to remind the witnesses that testimony is due no later than 48 hours in advance of a committee or a subcommittee hearing. I am told that the DAMA subcommittee did not receive VA testimony until late yesterday in preparation for today's 8 a.m. hearing. To me, that's unexcusable. And in addition, I and other committee members submitted a series of questions 7 weeks ago in relation to VA's 2012 budget request, yet no responses have been received. I would ask those here representing VA to please convey my disappointment about this performance and my expectation that things will improve in the very near future. And with that, I yield to the ranking member, Mr. Filner, for an opening statement.
Thank you, Mr. Chairman, and thank you for holding this hearing. Obviously, we want to gauge VA's response to several recent incidents that profoundly affect, as you have pointed out, veterans due to the failure of some to follow policies, procedures, and protocols that have been put in place to prevent such occurrences. We're going to look at what measures have actually been implemented to ensure that these types of lapses never happen again. I have to say, and I think you would certainly agree, Mr. Chairman, that we have been here before. You have acknowledge some of the events. Let me just point them out in just the most recent things. In December 2008, we were notified of improper reprocessing of endoscopes, which put thousands of veterans in Murfreesboro, Mountain Home, Tennessee, and Miami, Florida at possible risk of hepatitis and HIV. In February 2009, another 1,000 veterans in Augusta, Georgia received notifications that they were at risk for hepatitis and HIV because of improper processing of ear, nose, and throat endoscopes. In July 2010, this committee held a field hearing in St. Louis, Missouri, which you attended, Mr. Chairman, along with many of our colleagues here today, after we had learned of lapses in protocol with the cleaning of dental equipment, which put at risk 1,800 veterans. The most recent notification, the egregious incidents in Dayton, Ohio, affected over 500 veterans and involved a whole host of problems. The findings beg the questions of proper accountability, effective oversight, and enforcement of clear policies and procedures. Policies and procedures that are sometimes not followed or worse, get completely ignored are the issue. I would like to know, where is the strong leadership and effective communication that is critical when you are entrusted with the care and well-being of our nation's veterans? Let me point out another big concern as a result of these incidents, and that is the absolute need for effective communication within the management ranks and below, and also between management and the Congress. I'm sure the Secretary of Veterans Affairs agrees with me on this. Clearly, VA has had issues with ensuring the sterility of reusable medical equipment in the past, and now other patient safety issues have come to light, as evidenced in the continuing problem of veterans being vulnerable to infectious diseases due to the problematic yet prevalent issue of lack of following sound agency guidelines and policies concerning patient safety. In addition to what has been looked at over the past 3 years, I am strongly dedicated to the need for ensuring that we do everything possible so we don't trouble our veterans again. We are all well aware VA has a higher commitment and a moral compact to provide the utmost level of care possible. It is this committee's responsibility to ensure the VA has the proper resources to fulfill that mission. Of course, we want to acknowledge and recognize the VA's excellent health care services overall and the dedication of the vast majority of its staff, and of course the work that you have done so far to try to mitigate the issues that we'll be discussing today. I'd like to pretend that I'm looking forward to today's hearing, but I'm not. These are not easy questions. And frankly, Mr. Chairman, the issues go beyond just the incidents themselves. They go to the communication within the VA. It took a long time for the right people to know what was going on in each of these incidents. It goes to communication with our VA patients. Sending a letter that says, basically, you may have HIV is not the way to deal with these issues. There is no case management. There is no way for the veteran to really talk about what was happening, what the probability of infection is, how to get immediate help and blood tests and all the rest. A phone call going out or a letter going out to 1,500 people or 1,800 people without further explanation, without a 24-hour hotline to call back in. As far as I know, on some of these incidents, neither the Secretary or this committee was ever notified for days or weeks of the incident, as people trying in the VA trying to figure out how to I don't know, not cover it up, but try to stifle the whole thing, rather than allowing the most information possible. It seems to me that the culture of secrecy, the culture of covering up, is too prevalent here. Mistakes are made in every institution, and they will be made in the VA. But we have to acknowledge them, deal with them, get the information out as quickly as possible, and honestly figure out what happened. As far as I know, and maybe the panel can correct me, with all these incidents, we have never been told, I don't think so, Mr. Chairman, of any personnel changes as a result. The only way to send a message to an organization that we take these things seriously is firing or whatever. Now, I know you have all kinds of guidelines for this to protect employees' rights and information, but there's got to be a way, even in a public, even with these the issues of the employee rights, to understand there's accountability here. I don't know of anybody who's ever been fired. I don't know of anybody who's ever been let go. I don't know of anybody who has been specifically reprimanded, punished, dealt with when they put the safety of these veterans in hand. I think there probably have been, but we have never been told that. We have never even been told in general. You give us something, oh yeah, personnel changes have been made. That's not enough. That's not enough. That's not enough to assure us, and then that's not enough to assure the public. That's not enough to make sure that the good employees at the VA know that if someone makes a mistake, they're going to be dealt with. I think we have to find a new way to handle this, Mr. Chairman, and not just the procedures and the sterilizations, but how are you going to deal with accountability in a public institution when employees do have rights, but the public accountability is paramount. And we've got to understand that and deal with it in a new way. I thank the chairman.
Thank the ranking member for his opening statement. And as usual with this committee, we ask that all members hold their statements so that we can get to the witnesses, but each member will be allowed to enter their statement into the record without objection for printing purposes. And I would like to welcome the first panel to the table this morning, Dr. Robert Petzel, who is VA Undersecretary for Health, Dr. John Day, Assistant Inspector General for Health Care Inspections at the VA Office of Inspector General, and Mr. Randall Williamson, Director of the Health Care Team at the U.S. Government Accountability Office. Gentlemen, thank you very much for joining us here this morning, and Dr. Petzel, you may proceed.
Chairman Miller, Ranking Member Filner, and other members of the committee, thank you for the opportunity to discuss the Department of Veterans Affairs patient safety policies and strategies to build trust and ensure the safe and compassionate care of this nation's veterans. I'm accompanied today in the first row by Dr. Robert Jesse, the Principal Deputy Undersecretary for Health, Mr. William Schoenhard, Deputy Undersecretary for Health, Operations, and Management, Dr. George Arana, Acting Assistant Deputy Undersecretary for Health for Clinical Operations, and Dr. Andrea Buck, Acting Chief Medical Officer. I've submitted a written testimony and asked that it be entered into the record. First and foremost, I want to apologize on behalf of the Department of Veterans Affairs to those veterans who've been affected by these lapses in patient safety practices at any of our facilities. The primary commitment of every VA employee is the well-being of our veteran patients. When a lapse in patient safety practices occurs, we believe that we must be open and transparent with regard to our mistakes and any necessary actions that need to be taken. We carefully consider the effects of any disclosure, but our practice is to provide more information to our veterans in an abundance of caution, even if the risk is very, very low. We believe we provide excellent health care overall, despite caring for patients that are on average sicker, older, less affluent than the general population. VA's performance exceeds the best U.S. healthcare systems. We are very open with our information. We report more quality data about our programs online than any other healthcare system in this country. Our written statement provides an overview of our quality and safety programs, our practices for standardization of reprocessing, and our credentialing and privileging practices, and finally our risk management and notification for patients' procedures. For right now, I'd like to make 3 points. First, we are focused on continuous improvement to all of our programs. We publish an annual report on each facility's quality and safety performance online, and we're providing data to the Department of Health and Human Services website so that veterans can compare the care that's delivered in their facilities with the care that is delivered in the private practice. We conduct detailed investigations of not only adverse events, but of close calls, because even if a veteran wasn't harmed in a particular situation, We never want to put that patient at risk for that particular problem again. We subject our facilities to dozens of reviews annually. Our facilities are subjected to inspections by the Joint Commission, the Commission on Accreditation of Rehabilitation Facilities, the Inspector General, the Medical Inspector, the GAO, and a number of other external and internal quality and safety reviews. We not only appreciate this oversight, we welcome it. It is through these internal and external assessments that we can detect problems, identify best practices, and change the way we do our business. No matter what the outcomes, these reviews do improve the care that we deliver to our veterans patients. Secondly, we've made significant progress in standardizing, sterilizing, and processing reusable medical equipment across the country. Several of the incidents that are being discussed today were the result of improper reprocessing of reusable medical equipment. This is one area we're looking at for even further enhancements. We've standardized the purchase of reusable medical equipment, and we're using leases to ensure that the latest and best equipment is available, so that we go from 40 different brands of colonoscope at a medical center to less than 10 brands of colonoscope at that medical center, to simplify the process of re-sterilizing that equipment. We've created an Office of Clinical Consultation and Compliance that is implementing better tracking and documentation control measures over our reusable medical equipment. And we are subjecting our programs to the requirements of a program called ISO 9001. This is an industrialized, standardized process for quality control, and we're collaborating with the leaders in this field to improve our training, accountability, and practices in our SPDs. We're looking to work with the private sector to automate our practices to reduce the potential for human error. And 4 levels of review of our SPD programs are conducted. The facility does reviews, the network or vision does reviews, there are national reviews, and we have external entities that review our SPD processes on an annual basis. Finally, we have a careful assessment process to determine when we should disclose an event to veterans. We convene a fact-finding board to discuss the event and a clinical review board to determine if disclosure should occur. This rigorous process has been recognized by the New England Journal of Medicine as a best practice and a model for the rest of the country. These boards are comprised of subject matter experts from a range of disciplines to determine who should be notified and how we best should do that. In conclusion, our mission is to serve the nation's veterans by providing them the best health care anywhere. We take this responsibility very seriously, and we appreciate the opportunity to discuss these programs that we have in place to deliver on this promise. Thank you for inviting us to testify here, and my colleagues and I look forward to your questions.
Thank you, Dr. Petzl. Dr. Day?
Good morning, Mr. Chairman, Ranking Member, members of the committee. It's a privilege to discuss the published work of the Office of the Inspector General as it relates to the patient safety issues under discussion today. I believe that based on the body of work that we've done over the last several years, the VA does in fact provide high-quality medical care to veterans. Nevertheless, we're here today to discuss failures by VA to provide properly reprocessed, reusable medical equipment at the point of care delivery, thus resulting in the notification to thousands of veterans that they are at risk of becoming infected with blood-borne pathogens. My conclusion is that these instances result from 2 problems. One is the inability of selected facilities to follow established guidelines and directives with a zero defects culture. That is, to do their job correctly every day and every time. The second problem that I see from these issues is instances of leadership failure, where compromises were made to acceptable infection control standards that placed veterans at risk. I recommend that VA consider changes to their current policies and procedures and offer a few suggestions. 1, hospital leaders must have unfettered input from their employees. particularly those employees who I would call technicians. They run the lab, they operate the ultrasound machines, they provide and support a great deal of the care that's provided throughout the hospital. The nurses have a direct line of flow of data to the hospital leadership. The providers have a direct line of flow of unfettered data. I think it's imperative that the hospital director reach out and speak directly with the technicians to ensure that the data is congruent, that they're hearing about what's going on in their hospital. The second, I think VA should consider position rotations or forced vacations as a management tool in selected circumstances. Where senior hospital leadership is viewed as unresponsive to employee concerns, the quality of medical care may be placed at risk. The third, I believe VA has in fact an excellent adverse event disclosure policy that is in fact a national standard. However, I think in light of recent events, I think it is time to have a broader discussion of the risk management policies and the communication policies that entail this adverse event disclosure issue. And fourthly, I think senior hospital officials must very carefully examine those instances in which a provider has privileges at the hospital that are less than expected for that provider's position or recent history. A limitation of procedures alone may not provide the margin of safety anticipated by the credentialing and privileging committees. I thank you for this opportunity to testify today and will do my best to answer your questions.
Thank you, Dr. Day. Mr. Williamson. You might check your mic real quick.
I'm sorry. I am pleased to be here today to discuss our report issued this morning that addresses VA policies and oversight governing the cleaning and disinfecting of reusable medical equipment, which I will refer to as RME. Lapses by some medical centers in cleaning such equipment, which includes dental instruments, endoscopes, and surgical instruments, have recently come to light. Such lapses have put thousands of veterans receiving care at these medical centers at risk to exposure of HIV, hepatitis, and other infectious diseases. In my testimony today, I will describe our findings in two areas. First, I will address deficiencies in VA policy requirements for training its medical center staff to properly clean and disinfect RME. And second, I will discuss needed improvements in VA's oversight of medical center staff to ensure that they comply with these policy requirements. Regarding the first area, we visited a cross-section of 6 VA medical centers across the nation and found some disturbing deficiencies with respect to VA requirements for device-specific training for cleaning and disinfecting RME. These deficiencies indicate systemic problems that need to be corrected at the national level. Two issues came to light here. For one, almost all medical center officials we talked with said that VA guidance was unclear as to which types of RME require device-specific training to ensure proper cleaning techniques. This resulted in device-specific training not being developed at all 6 medical centers we visited for some critical RME, such as surgical instruments. At one medical center, for example, officials told us they had developed device-specific training for non-critical RME, such as wheelchairs, but they have not completed training for more critical RME. Another training issue involved conflicting guidance that was provided to medical care staff about how to clean RME. Officials in 3 medical centers, for example, told us that certain headquarters or visiting officials had told them to develop device-specific training for RME that closely matched manufactured guidelines. Later, other headquarters and vision officials told them to write reprocessing instructions in a way that could be readily understandable rather than strictly following the manufacturer guidelines. This led to multiple rewrites of training instructions by medical center staff, which was both time-consuming and a waste of resources, and could lead to preparation of insufficient training instructions for cleaning RME at some medical centers. Headquarters officials told us they are aware of these deficiencies and have begun efforts to remedy them. For example, VA officials said they have recently gained access to a commercial database of standardized device-specific training developed by manufacturers for over 1,000 pieces of RME and have made this database available to medical centers. For RME where manufacturers have not developed device-specific training, VA officials said they plan to develop this training and provide standardized instructions to its medical centers. But at the time of our review, VA had not yet done this and had no firm plans or timetable for completing this task. With respect to RME oversight, VA has recently initiated efforts to improve its oversight of medical centers with respect to complying with RME reprocessing requirements. These efforts include increasing the frequency of unannounced site inspections to medical centers, requiring visits to use standardized assessment tools, and requiring the results of RME inspections at medical centers to be reported to headquarters. Despite these changes, improvements in VA oversight are still needed. Most notably, while VA now requires that all RME inspection results from its medical centers and visits be submitted to headquarters, VA does not systematically analyze this information across its medical centers. Such analyses are important to assess the extent and risk of noncompliance with RME reprocessing requirements across its medical centers and to determine whether identified noncompliance cases have been addressed. VA headquarters officials said they plan to address oversight weaknesses we identified, including analyzing information to identify noncompliance with RME requirements across its medical centers. However, completing these changes is contingent on implementation of a VA organizational realignment in this area, which was still ongoing earlier this month. In summary, while VA has taken some steps to strengthen both its methods for reprocessing RME and its oversight over this process, much remains to be done. Until VA's improvement efforts in this area are completed, veterans may continue to be at risk to RME-related infectious diseases. Thank you, Mr. Chairman.
Thank you for your testimony, and we will start a round of questionings, and as our usual course, committee members will go first, and then we'll have a round for the non-committee members as well. But on my time, and I'll adhere to the 5-minute clock as well. Dr. Petzel, would you like to respond to Mr. Williamson and his presentation regarding their report?
Thank you, Mr. Chairman. I would. We appreciate both the GAO and the IG inspecting our reusable medical equipment processes as well as the other things that they do, because as I said in my oral testimony earlier, we do learn, and we have concurred in the recommendations that the GAO specifically made. I want to point out a couple of things. Number one is that we do now have a standardized database that covers the majority, the vast majority, in fact, of the processes, the standard operating procedures for processing reusable medical equipment. And that means that we do have, across the country, standardized operating procedures for cleaning. In those areas where the commercial database does not cover, we've developed those ourselves. And contrary to what Mr. Williamson said, we do not tolerate people writing their own procedures. We have a standard for cleaning whatever that piece of equipment is across the country. It may not have been completely in place at the time they did their inspection, but it is now, and it is our practice around the country.
If I could, on number one, you said in place for most of, but the implication is not all.
Well, what I said was that the commercial database that we bought does not cover absolutely everything. And we have developed, or we have in place, processes for those things not covered, which are relatively few, not covered by this database that we purchased.
Give me an example of what wouldn't be covered. Can you?
There might be some small surgical instruments.
Does that mean you wrote them, or?
That means the manufacturer has them, they're not in the database, and we use the manufacturer's information.
So you do have everything covered, but some is not in that database that you purchased?
That's correct.
Okay. And number two?
And number two is that the training that was described in the GAO report is in fact in place and has been done in the vast majority of our places. We have begun a process of certification for all of our technicians. We have developed an institute or an academy of SPD where we bring people specifically down to go through the training process. We require that every SPD document the fact that their people, their technicians, have been trained on the instruments that they're responsible for reprocessing. And I believe that the last look that the IG made at how well we had done with that training indicated that we were close to, but not yet perfect in terms of the number of people that were trained. In other words, there were some instances where they found no evidence of the training, not that the training hadn't been done, but no evidence. So that's number two, is that we have indeed set up a process for ensuring that our people are properly trained. And then the last item that I wanted to discuss in the GAO report is a central office oversight. Again, a point that we agreed with, that we need to have in place the mechanisms that allow us to be assured and are able to assure our patients and you all that we are periodically looking at the SPD and how it's functioning and assuring ourselves, you all, and the public that indeed those things that we say need to be done are being done, the training, the following standard operating procedures, et cetera. As I mentioned in my oral testimony, there are 4 levels of oversight that occur in the SPD. There is a local requirement for oversight. We changed the reporting structure in SPD to a clinical person, the nurse executive in the executive quadrant. We require that the networks periodically, 3 times a year, inspect the SPD using a standardized assessment tool, which I think most people would agree is probably a benchmark standard within the industry. Then we, from central office, do our regular periodic inspections of the SPD for both infection control processes and reprocessing. And then finally, as mentioned, there are a number of outside organizations that periodically look. The IG does their combined assessment programs that include looking at the SPD, and that's done every 3 years. The Joint Commission looks at SPD. The medical inspector periodically looks at SPD. We have an internal source process that looks at SPD. So there is at least 9 levels of oversight of SPD right now.
Let me, and my time has run out, but comments, I think in your opening statement, continuous improvement, dozens and dozens of reviews annually, careful assessments. You talked about 4 levels of oversight. I think GAO talked about inability to follow guidelines, a need for unfettered input from employees. They found disturbing deficiency and systematic problems. You said you've begun a process of certification. If you do all of those things and your managers don't follow the rules, what do you do with those people?
We would discipline them.
Have you?
We have.
Have you fired anybody?
We have proposed removal in a number of instances, and almost invariably the individual has resigned or retired as a result of the proposed removal.
Can you give us a number, I mean, of individuals that you've proposed removal of?
There are, I believe, 3 physician or dental level people that's occurred with, several chiefs of SPD where that's happened. We have also reprimanded individuals, suspensions, and letters of counseling.
And I think one of the dentists was in his 80s. Is that correct?
Close, yes.
Mr. Filner.
Dr. Petzel, you're here as the representative of the VA. We've gone through this before, sir. It seems to me your job here should have been, and we have Congress people from all the districts that have been affected, was to begin to restore some trust and confidence in your institution. I hate to take a poll. If I did, I said, how many people now have confidence everything is fine in your VA hospital? I doubt if anybody would raise their hand. You said everything was fine. It's not true. Simply not true. You talk about all these transparent procedures and these New England Journal best practices, and yet every time something happens, we have disaster. We don't have a way of communicating. We don't have a way of dealing with the personal concerns. We don't have any knowledge that anybody has been reprimanded. Now you got 3. We've been going over this for years, and now we got 3. And you've never told this committee those figures before, as far as I know. But, Dr. Pretz, we've gone through this before. We've raised concerns in our opening statement. You read your opening statement as if we never said anything. So you never addressed issues of accountability. You never addressed issues of communication, whether within your agency or with veterans or with this committee. I've gone through the timelines with almost every one of these members here in their hospitals. You say panels get together to decide, should we disclose, what should we disclose, who should we? It looks to many of us like they get together to decide, what do we keep secret from our, you keep shaking your head no. But why did it take 8 weeks at St. Louis, where Mr. Carnahan will raise the issues? Why did it take 8 weeks for that panel to decide we're going to tell people that we have almost 2,000 people infected with HIV? It took 2 months before you guys decided that. I would have notified, and the secretary wasn't notified, as far as I know, in his words to me, in that whole period of time. So it sounds like you're sitting there deciding, what's the minimal amount of information that we can give out so people don't get upset with us, rather than the maximum. First day, I would have had the secretary had a press conference and said, we have a possibility of X hundred or X thousand of people. We're going to get to you right away. We want to make sure you know this is happening, and put pressure on yourselves to become public, because there's no pressure for you to do anything. We didn't know anything. The secretary didn't know anything. I don't know if you knew anything, because these guys are going to basically meet. How do we keep this secret for as much long as possible? Maybe we don't have to disclose it all, because your question was, should we disclose? Not how to do it. And then, as I said, your whole disclosure process is as if everybody knows all your acronyms and your initials for everything, all these SPDs and RMEs, as if the patients know what's going on. They get a letter. I've seen these letters. It says, basically, it's not this bald, but almost, you may have HIV. They get a letter. It may have even gone to a wrong address. For 1,500 people, as I said to you earlier at a hearing, you should have had 1,500 of your 250,000 employees assigned each one to somebody. Call them, go visit them, find out where can they come back, when can they get their blood test. Treat them as if they may have HIV and they're scared to death. They're going to die. And you send them a letter. And there's no one necessarily there to answer a phone call when they call back, because you don't have people working this like case managers and 1 person to 5 people, or I think you should do one-on-one. But what you described as this open, transparent process does not come through. And every one of these people has constituents, which I bet confirm what I just said. And even if it's perception and not reality, that's just as bad. That you took forever. You weren't very personal in your notification. You weren't very clear about what it is that they might have. You didn't follow up in a way that was very quick. And then we don't know anything about accountability. We know nothing from basically what you said today. And you guys have got to develop a new system, whether it's talking. We just killed Osama bin Laden, and they notified 8 members of Congress and the committees, and they kept that. Well, maybe you should notify, the chair and ranking member of all the veterans committees about what you're doing in terms of your personnel. But there is no sense that you have done anything. And we don't know, nobody in Dayton, nobody in St. Louis, nobody in Miami, nobody in New Jersey, in Tennessee knows anything about that accountability. And I doubt anybody in the system knows about it. So they don't think there's any accountability. So I wish you'd address these issues. We've gone over them for several years. You and I have gone over these exact issues several times in hearing, and you do the exact same thing. You give me a prepared statement, everything's fine. You move the discussion into these arcane things about SPDs and RMEs, and you neglect the basic issues of communication and accountability that are at the heart of the confidence that our people have in your system. You may comment in any way you want.
Thank you, Mr. Filner. What I want to do is first talk about our notification process. The process by which we determine who ought to be notified or who might be at risk, as I said before, is an industry standard, and I will stand by that process under any circumstance. It takes some time, but it is transparent, and it is weighted heavily in the favor of...
Nobody knew about St. Louis for 8 weeks. 8 weeks.
Sir,
If that's the industry standard, we shouldn't be following the industry standard.
Sir, I'm not talking about the communication. I'm talking about the process that we go through. It is very thorough, and it's weighted on the side of being abundantly cautious to be sure that we take into account every possible risk. The process by which we disclose to patients involves letters, phone calls, and case managers. Particularly in the instance of St. Louis, every single individual that was affected was called. They were offered a case manager. There was a case manager that involved, in fact, in some instances, the leadership of the medical center. I will admit that we've learned iteratively since the first episode.
Sir, that conflicts exact with what you said to me at St. Louis. The chairman was there, Mr. Carnahan was there, and then Mr. Lacey was, Clay was there. Sorry. Mr. Shimkus was there. You never mentioned the word case manager. You never mentioned that they were called. Is that right, Russ? I mean,
no.
we went through this discussion with you. It's the first word I ever heard of a case manager. Because I said to you, why don't you have case managers? You said, yeah, we'll look at that. We're both going to review your testimony in St. Louis because it's contrary to what you just said now.
Again, we have learned iteratively about the process of notifying people. And early in this, with the first episodes that we had in Miami and Augusta, I don't think we did a good job, to be very candid with you. But with the next several episodes, I think we've done a better job of sending letters, calling people, and giving them a hotline call, a hotline number to call, and making people available to them to answer their questions about what happened. And again, after reviewing what's done across the nation, I would stand by the process that we have right now as being an excellent way of notifying people when there has been potential exposure.
I hope all of our non-committee members who are here will speak to those issues from the way you saw them or your constituents told you. I hope so. Thank you.
Dr. Rowe?
Thank you, Mr. Chairman, and not too many questions, but having served as a chief of staff of a hospital and a hospital board chairman, you are responsible, when you feel that responsibility, for the care that is given by your institution. And I've noticed a couple of things here that bother me a little bit for the last couple of years, is that when you have, and when we talk about where the instruments, SPDs, where instruments are cleaned, it really gets down to 1 or 2 or 3 people in any hospital that's doing this. It's not a whole big system, it's people doing it. And those people probably think they're doing the job right, but if they haven't been trained to do it properly, they're going to continue to do it wrong. I can assure you that in the private sector, had this occurred, like this just occurred, and a medical legal case had resulted out of it, you just get your pencil out and start writing commas and zeros. I can tell you and get the checkbook out, because this private system would not tolerate this. I can tell you right now, when you have this go on, and I think you know that, is that if this occurred to me, and I'm the doctor that does this, no matter if it's the SPD that does it, I know who's captain of the ship, and I know who's going to be responsible for that error that's occurred. And there have been numerous errors here. And one of the things that we have to sell in medicine is trust. Our patients need to trust us. They need to trust the VA, that's where the quality of care and transparency. Mr. Filner is absolutely 100% correct. I can assure you that when I had a problem go wrong in my shop when I practiced medicine, not the clerk that answered the phone made the call to the patient. I made the call to the patient. I called them up, I explained to them, I had them come in and tell them what was going on. And I can tell you, with 1,500 people, that could have been in a large institution with multiple people. I would have had the highest level people contacting someone when they think they have HIV or a potential life-threatening condition. Now, because these instruments were cleaned in a certain way doesn't mean that it gave the patient that. I mean, we don't know what the incident was to start with. I mean, we don't know in these patients, we don't know, but they don't know either. So I think Mr. Filner is absolutely dead on right. And it's not the crime, it's the cover-up, or even perceived cover-up. I mean, nobody's trying to hide. I don't think you're trying to hide anything. I know that. In my gut, I know that. But you've got a huge system, and you have to put systems in place where people are trained and to where their training is evaluated so that those things do not occur. And I don't have the feeling yet that that's been done. Maybe it has been. Maybe you can make me feel better, but from what I hear from Mr. Williamson, he didn't see it that way. Comment.
Doctor, could you hit your microphone?
Thank you, sir. I do believe it's up to our oversight processes to assure you, and assure the veteran population that, in fact, those things are being done. We've learned a lot from these episodes going back to 2008, and I think we're a better system because of it, and I think we do have the best, if you will, in terms of reprocessing an SPD that's available in this country right now.
When we did, one of the things that we had in our medical legal training in Tennessee was we had the airline people come to us and go over their procedures, which are absolutely textbook down when you take a plane off, and you'll almost find out every time it's a pilot error. And what you'll find out here without oversight, it'll be an individual person making that error, as in the dentist example you gave. But that wasn't dealt with. That's the other problem, is that when you see that problem, it has to be dealt with. You can't, I've done that. It's not fun to go in to talk to somebody who's a 30-year member of your shop and say, you're not performing at the level we accept. That isn't easy. I've done that. That is very hard to do. And I don't get the feeling that that was handled very well when that this problem apparently was identified for years and never dealt with. So, again, you have to have those procedures in place, and then you have to follow those procedures, and they have to be lockstep. If you don't, you'll have these errors. And I think the other thing you're doing is it's much simpler when you have the same equipment all the time, when you have multiple kinds of equipment, and doctors are terrible about that. We have our little toy we like to play with. But we can play with any toy if we learn how to do it. And when the fewer toys you have, the easier it is to not make those errors.
Yeah, I absolutely agree with that last comment. We are frantically standardizing our reusable medical equipment. We just signed 2 lease contracts for colonoscopes and endoscopes with only 2 manufacturers. The fact that they're leases means that we will be able to turn over the latest model. What has happened in the past is that they'll buy some new endoscopes, but they'll keep the old endoscopes as well. So you've got maybe 7 or 8 years worth of models, all of which have different instructions about how to clean, et cetera. This is going to allow us to have only the most up-to-date models and many, many fewer instruments that we have to learn the procedures for cleaning from. I think that's an excellent point.
Thank you. I yield back.
Mr. Walz.
Thank you, Mr. Chairman, and thanks to all of our witnesses for being here. And I, like Dr. Rowe, was at that hearing a few years ago on the endoscopes, and I do appreciate some folks brought several into my office and taught me how to do it, because my My goal was to see exactly what the procedure here was, and I want to be very clear, everybody in this room, the care of our veterans is the #1 concern, and I absolutely have no doubt of that. It is a zero-sum game. One injured veteran is one too many. But I want to bring up, Mr. Williamson, to you, and I was looking at a recent New England Journal of Medicine report. Let's be very clear here that this is not a problem associated with only the VA. How do the private hospitals report this when I hear numbers of 98,000 deaths, 1.5 million injuries per year in the private sector? And I was, Dr. Rowe, I'm going to have to get with you on that. I almost thought I heard you saying that the threat of legal action kept people doing better things, but I'll clarify that with you. But the idea on this is how prevalent, can you make any comparison to, is this systemic with the leadership in the VA or how things are done, or is this a broader problem, which I would argue representing places like the Mayo Clinic and VA facilities, that is systemic across the board in medical delivery?
Well, Mr. Walsh, you may be right about the breadth of it, but we basically concentrated on VA and we didn't examine any private sector data in this regard.
So we don't have the ability then to, we were using best practices there, but the argument I would make is, are we absolutely certain, and don't get me wrong, one is too many, but are we absolutely certain the practices being applied in the VA are worse than the private sector, even though that our goal is to have it the best care? Dr. Petzel, do you?
Congressman Walsh, thank you. I can make just a couple of comments. The New England Journal of Medicine article that I was describing before that cites us as being the best example of how to assess risk and how to contact patients, also cites 18 other examples of potential exposure across the country, ranging from 40,000 people in one instance to just a couple in another. It's a prevalent problem across the country. I believe, and we have had some confirmation of this from other people, that we are doing an excellent job of trying to achieve a Six Sigma performance in our SPD. The ISO 9001 that I spoke about before is an industrialization of the whole process. Very few other people are doing that in their SPDs. The inspections that we go through are not done in many other parts of the country. So I think that, I mean, I don't want to compare us to the private sector completely, but I think we're doing a good job. Not a perfect job, as has been pointed out by a number of people. We have to do better, and we will continuously improve this. But I think we're on the right path.
So the Six Sigma process is translating. Are we focusing on the 1/1000th in here? Because I said, even if that's what it is, we're going to focus on that.
That's the
care of our
kind
veterans. Is that what's
of
happening?
performance that we're trying to emulate, correct?
That's right.
I would add, too, though, that we looked at VA policies and what VA requires and a standard of excellence that they require of their people, and that just, I mean, you can compare to the private sector, and I really don't know what's going on there, but you really need to compare it against the standard of excellence that VA set for itself, and it wasn't doing the jobs.
Yeah, good point. And that, I think that Dr. Petzel, you agree with that too, because I think the question, the frustration coming from my colleagues is that whether it be communication or very disturbing to me with the dental incident of someone actually passing on informations of poor practices, less than best practices, and yet the appearance wasn't anything done about it. I think that frustration that the chairman experienced asking, well, did you remove these people? Because are there barriers to doing that? I want to be very clear on that. Are our managers given the freedom to be able to make changes in due process with basic principles, but are they able to do that?
They are. The civil service rules are complex and complicated, but if you follow the right processes and procedures, it is possible to do that. I want to just make a comment about Dayton and the dental. It's come up a couple of different times, and I want to be perfectly clear. That was a failure of leadership. That was a failure of leadership within the dental clinic. The people that worked with this individual knew that this was not appropriate. The technicians knew that it was not appropriate. The chief of dentistry knew that that was not appropriate, and for a long period of time, none of these people took the kind of action that they needed to take. And unquestionably, that's a failure of leadership.
Well, I appreciate that. I appreciate all your work, and as I said, I am, of course, your biggest supporter, but I will also be your harshest critic until we get this down to the best anywhere. So I appreciate that, and I yield back.
Johnson.
Thank you, Mr. Chairman. You know, as a former Air Force officer myself and as a veteran, I'm very concerned about what I'm hearing here. You've mentioned several things. I heard earlier in your testimony, or in response to one of the questions, you indicated that none of the technicians were permitted to write their own instructions, that there are standards to follow. I think you also expressed confidence in in your oversight processes to catch these things. And just now, to my colleagues' questions, you talked about how everyone in Dayton knew that this was going on and that it was a failure of leadership. Which leadership are you referring to? Where's the failure?
I didn't refer to everyone in Dayton knew this was going on. I referred to everybody in the dental clinic
Right,
knew
okay.
this was going on, and I think the primary failure there was the leadership in the dental clinic.
Okay. Well, let me refer you to a GAO report that came out today. Title of it says, "Weaknesses in Policies and Oversight Governing Medical Supplies and Equipment Pose Risks to Veteran Safety." Down in the oversight over reprocessing requirements, let me give you this quote. It says, "Although VA headquarters receives information from VISNs on any noncompliance they identify, as well as VAMC's corrective action plans to address this noncompliance, VA headquarters does not analyze this information to inform its oversight." Dr. Petzel, how can you express such confidence in an oversight process that doesn't even properly identify and analyze the information coming up through the system? And I submit to you that the failure in leadership is not just at the dental clinic, it's right here in Washington.
Well, First of all, Congressman, the issue in the dental clinic in Dayton was not one of reprocessing. This was one of infection control and the practices of a particular individual.
But aren't those covered under your oversight processes?
In a different manner than the reusable medical equipment, but yes, there are some oversight processes associated with that.
Well, let me take just a second. Why GAO did this study? Department of Veterans Affairs VA clinicians use expendable medical supplies, disposable items that are generally used one time, and reusable medical equipment, which is designed to be reused for multiple patients. And this GAO study looked at all of that. So they're looking at not only the reusables, but they're looking at the exposables, and they identified serious weaknesses in the analysis and identification of the information that comes to VA headquarters. How do you respond to that?
We agreed with them, and we agreed that that was an appropriate thing to be doing, and are now instituting the process to do that, to systematically look at the information we get, to look for trends, to look for possible themes that run through those things, and we are now doing that. We agreed with them that that was a wise thing to be doing.
Yeah, I guess I refer back to my colleague, Mr. Fellner. You know, we've been talking about these things for a very, very long time. Why are we just now starting? You know, I met with a group last week, whether it's in the oversight of expendables and reusables, or whether it's in oversight of the claims process. I met with a focus group that has identified glaucoma cases where patients, veterans have been identified with glaucoma, and yet their referral for treatment took so long to get through the system that by the time it actually came up that they got treatment, it was too late, and their condition was irreversible. And in the oversight and investigation arm of this committee, I can assure you we're going to be looking into those as well. So How can we say that your oversight processes are even close to being adequate? And why are we still talking about these things rather than doing something about them to protect the health and welfare of our veterans?
Well, Congressman, we haven't just started doing this. We've been doing this for a
But that's what you
considerable-
just said. That's
No, I
what you
didn't.
just said.
I
You said we're now
that
doing it.
I said that particular aspect of the oversight is something that we're beginning to do early in 2010. But the process of looking at RME, of improving RME, of oversight, of training, et cetera, these began quite a long time ago, and they have been continuously improved since our first instance of exposure, possibly, back in 2008.
My time is up, Dr. Petzel, and I'm going to yield back, but I want to just summarize with this, and I agree with my colleague, Mr. Filner. If there's anything that it appears that the VA is expert in, it's talking around these problems and kicking the ball down the stream in a number of areas. We don't seem to get specific solutions to specific problems that greatly affect the health and welfare of our veterans, and that's a very concerning scenario to me. Mr. Chairman, I yield back.
Mr. Reyes.
Thank you, Mr. Chairman, and thank you, gentlemen, for being here this morning. I wanted to ask if there was a way to compare the what is occurring at the VA in terms of these particular issues, failings, with whatever the standard might be on the civilian side, or perhaps even in other systems similar to the VA. Even if we're considering other countries. I understand that my colleague, Mr. Waltz, asked something similar, but I had to leave for a little bit, and so I apologize for doing that. But I wanted to know if there is a basis for comparison about what's occurring at the VA.
Well, Congressman Reyes, there is and there isn't. First of all, however we compare to the civilian sector, the fact that this happens to even one of our patients is not a good thing. It needs to be changed and needs to be improved. So on the one hand, it's almost irrelevant how we compare to the private sector if we're allowing these things to happen. I think we need to address that directly. In the ways that we are able to do this, such as what is our disclosure policy like? How does our disclosure process work? We can compare that to what some private sector people do, and ours compares very favorably. In terms of the incidence of this happening, it's not possible to compare it. And again, I think that's irrelevant. The fact that it happens once is too often in our system, and we need to be working in the direction of this not being able to happen ever again.
I understand.
So it's very hard to compare. I just have to say it, it's very hard to compare.
Well, first, but my point is, and you're right, even one instance is one too many, but the reality is, and that's why we have lawsuits against doctors, against hospitals. Sponges have been found stitched in after operations, and scissors and all those kinds of things. The reality is that those kinds of things exist and happen in medical treatment. My point was, if we're going to, are we, in essence, holding the Veterans Administration accountable realistically compared to other medical systems, or are we in a situation where perhaps the VA needs to have an assessment, a self-assessment of the quality of health care that's going on, because perhaps incidents are much higher than they would be in other kinds of systems. That was the point of my question. Yes, we can criticize you for every single misstep, but you know, we all should strive for perfection. But the reality is, perfection does not exist in the medical world, just like it doesn't exist anyplace else. We're seeing the shuttle delayed by a week or so because of a mechanical problem. So, and that's in a system that is designed by all the checks and double checks and triple checks to be a zero defects operation. So that was a question that I had.
Congressman Reyes, I appreciate that. First of all, as the gentleman from the GAO said, we have to be held accountable for following the policies and procedures that we've got out there. I mean, we should. Number one, and number two is that whatever the comparison might be between the private sector, we need to, again, be held accountable for how we do. And I think that the goal has to be that we don't leave any surgical sponges in a patient's abdomen, that we do not fail in our reprocessing efforts with any piece of reusable medical equipment that we have. I mean, that needs to be the standard against which we're judged, not necessarily what goes on. So I appreciate the concern, and I appreciate the angst that people feel about the failures that we have. And I don't want to excuse those by saying that we're better than the civilian sector or whatever. We've got to solve those problems internally by having the right policies and procedures, by following those policies and procedures, by having the kind of oversight that's necessary to assure us that that's happening. And then, as you all have said repeatedly today, we need to hold people accountable if they don't follow those procedures.
If I could add to that, I think Chairman Miller, you hit it on the nail on the head initially when you said that you could have all the requirements, very good requirements, but if people are not following them, therein lies a problem. And let me just give you one example. In July 2009, the VA came out with a directive for its medical centers. It said you shall have or you shall develop device-specific training for your RME equipment. When we went into St. Louis in the fall of last year, they had not developed that kind of training requirements for 80% of their RME. And that was 15 months after the directive came out, and it was 6 months, we were in there 6 months after the initial incident with the dental instruments. So I think, again, it's tough to compare the private sector with VA. I think VA, in many cases, had very good policy requirements and very good policies, but you've got to get people to implement them.
Thank you. Mr. Ryan.
Thank you, Mr. Chairman. I was just going to ask, perhaps the question that needs to be answered is, as we talk about accountability, how when issues like this come up, how they respond to it, not just with procedures, but accountability by the people that have been involved, which, by the way, when Dr. Pretzel mentioned, the secretary has been in my district, and I think Mr. Filner was there with us. His goal is to have the best available healthcare system on the planet. That's been articulated. We just have to make sure that there's accountability.
Mr. Runyon.
Thank you, Mr. Chairman, and thank you all on the panel for your testimony. I actually just chaired the DAMA committee hearing that the chairman spoke about earlier. And I want to go back a little bit to what I ended up saying at the end. And I know the chairman and several other of the subcommittee chairmen have had meetings with Secretary Shinseki, and we talk about accountability. The fact that we use the word oversight means there's a total lack of accountability. It really needs to leave our vocabulary, because oversight means there was a mistake, and we need to move on from that, because we all agree to that fact. But going back to the dental scenario we were talking about, that everyone knew it was going on, have we made any steps in developing procedures and or whistleblowing within that management team and moving that direction to, really stop something from like that to happening, because I think that's another place where I know people are afraid of stepping on toes of people senior to them. And I really think it needs to be addressed, because obviously there's a situation where that did not need to be happening. I think if you had procedures and protocols in place, you could have avoided those situations.
Congressman Runyon, you make an excellent point. What was missing and what needs to be there and needs to be in all of our medical centers is what's developing in St. Louis, and that is an atmosphere where people can come forward, as you said, to the management, to whoever they need to come forward to, and say, this is happening, this is wrong, somebody needs to look at it. And that didn't happen at Dayton. And for a long time, that didn't happen at St. Louis. There's very good evidence that things are changing in St. Louis, and my expectation is with the management team that's now in place in Dayton, we're going to create that same kind of atmosphere. Not only do people need to be able to come forward, but the management team needs to be able to sit down and candidly discuss what's going on in the medical center to keep each other informed, as well as hearing from what's coming up. And again, just to reiterate, that was not the case at Dayton.
I think we can all totally agree on that. And, you know, my experience with dealing with higher powers is, you know, a lot of times the truth hurts. And I think to be able to have that communication, open communication in a team is desirable no matter what team you're on. And you really have to make a push for it. And, you know, you just take the attitude of, you know, just to the procedures that are in there, the standards are in there. And, you know, the accountability you have personally to just get the job done. And not worry about, you know, what my superiors are thinking, but knowing that whether someone lower down has the backing of the secretary and is going to blow the whistle, they need to be informed and assured that if they do blow the whistle on someone, that it's not going to cost them their job and or their career. Well, with that, Chairman, I yield back the remainder of my time.
Mr. Carnahan.
Thank you, Mr. Chairman and Ranking Member Filner. You all have been on this issue. You both have been to St. Louis with a Missouri-Illinois bipartisan delegation, and appreciate your commitment to this issue. Also, I want to make just a brief personal thanks to Felicia Woods, who's LA on my staff, who's going to be leaving to go to the Peace Corps after this hearing, and want to thank her for all her great work for my office and for veterans in St. Louis. Also, the Veterans Advisory Committee that we work with in St. Louis, we're back home watching this hearing today, and the many committed medical professionals at Cochrane that are committed to reforming that institution. I spoke with Director Rima Nelson a little over a week ago. She described to me that they're working on a comprehensive turnaround plan, that they are working to incorporate many of these recommendations, excuse me, from the GAO and the Inspector General that can help this facility be what it needs to be for the veterans in St. Louis. My question for Dr. Petzel is, are you aware of this plan? We were promised to get a draft copy of it by the end of last week. We've yet to receive that, but I think it is critical to turn that facility around, to have such a plan, to get buy-in from our veterans, our community leaders, because we want them to succeed. But I think they have to have an aggressive plan to make that happen, and they haven't had it up to now.
Congressman Carnahan, I have not seen yet the plan. As soon as we finish with this hearing, I'll get in contact with the director, Rima Nelson, find out where it is, and if she has promised a copy of it to you, we'll be sure that you get it.
To me, that's a critical point going forward. And to the point of reforming the adverse event disclosure procedures, we may have the best scientific procedures there are in the world, but if it doesn't reflect the human impact on veterans, it's not a good system. We've got to have the human side of that system in place. And to Mr. Filner's point, at the hearing in St. Louis, there was not a case management part of this in place. People in St. Louis, they got a cold form letter like a parking summons in the mail. That's it. And so that's when folks at the hearing said, at the request from many people at that hearing, that they would follow on and have the more personal follow-up. So I appreciate that that happened, but that's not where this started.
Thank you, Congressman. I will have to go back and review my recollection of that. I do know that we eventually ended up with case managers' phone calls in addition to the letters, and you may well be right that that occurred after the hearing. I just don't remember the sequence. And
I am right, and that is the way it happened.
Okay.
So we don't need to review it. That's the way it happened.
I will believe you.
Anyway, the other thing, in light of the incidents at Cochrane and other medical centers around the country, at what point is the management evaluated at these institutions, and are they held accountable? Again, I'm very pleased that the management at Cochrane is developing this plan, but what we've heard from Mr. Day and others, there have been repeated visits, citations, problems that have not been addressed, starting with his work back in March of '07, another visit and evaluation in August of '08, May of '09, March of '10, and then, of course, the congressional hearing in July of last year. And a lot of these problems are still lingering or not fixed yet. And, you know, the question is, how many times do our veterans have to fall in the same pothole before we fix it? And so I want to have this system in place. I want to have a comprehensive plan in place for Cochrane. I want to get the community and veterans to buy in. But at some point, people have to be held accountable if it's not implemented.
Absolutely agree with you. Absolutely agree.
Mr. Chairman, my time is up, and thank you again, and I yield back.
Thank you, Dr. Benishek.
Thank you, Mr. Chairman, Mr. Filner, and thanks for the panel here. I worked at the VA during the time of this colonoscopy event, and I was aware that they shut the whole thing down. So it has some personal meaning to me. And I guess what I've found here is, I guess you talked about this dental clinic a little bit, but are those people that you identified here in your testimony, you know, the dental supervisors, facilities chief of staff, I mean, that the dentist in question, I mean, did those people been punished, or have they been fired, or what exactly happened to those people?
I'll have to speak generically. The principal in question has retired, and there's no way that we can prevent somebody, even though we may want to discipline them from retiring.
What about the chief of staff, then?
The chief of dentistry is I believe, has resigned as well. And the chief of staff of that medical center, we have not yet determined what the situation is going to be. There are three administrative investigative boards going on right now as it relates to Dayton, and we don't have the results of those yet.
All right. This is the kind of thing that is frustrating when there's, you know, a serious lapse of leadership that you mentioned, and yet, you know, significant amount of time has gone by and you haven't decided what to do with this guy or gal. And the other thing that disturbs me is Mr. Williamson's testimony about the 15 months elapsing between the, you know, the saying that you're going to be doing an implementation of a protocol for cleaning RMEs, and then he reports that 80% of that hasn't been done 80% of the places after 15 months. I'd like to know who's responsible for that. I mean, who's the guy in charge of that implementation of that process? And
just a comment. There were 6 medical centers that they reviewed out of 152, and I don't know where those medical centers were. If the GAO is willing to identify them, we would be delighted to go in and look and see what the problems were and what happened.
Why didn't you ask him before this?
I beg your pardon?
Why didn't you ask him to identify it?
I just got the GAO report.
Well, it's just frustrating to me to have, you know, we got two agencies of the government here with sort of conflict. And you know, Mr. Williamson seems to identify an area of leadership there's something wrong, where there's 15 months and now I can't, how do I understand this information? You're saying one thing, he's saying another, and we're trying to decide how to best treat our veterans. I think we definitely need to follow up on this, you know, from this committee further, and make sure that there's, you know, not only at the chief of staff level, but higher up in the chain of the bureaucracy, that we have effective leadership and accountability for those people at each of those higher up positions. Mr. Adamson, did you have Williamson, did you have a comment?
Oh, by the way, we went to Albany, Cheyenne, Detroit, Miami, Palo Alto, and St. Louis. You know, the fact it's only 6, we can't, you know, obviously we can't travel to 90, and what we try to do when we go to a location is we look for systemic problems that transcend one facility. So while you only may go to a small number, you're verifying that something's missing throughout the system. So that's kind of the methodology that we use. I got to say that we have a very, as most of the members here who've been a recipient of GA reports, we have a very rigid and rigorous process for verifying our information. And all the things that I've told you in the report and in my opening remarks, VA's agreed with. We have an exit conference with VA. We give them 30 days to comment and so on, and we verify that pretty rigorously. So I don't think Dr. Petzel is disagreeing with the 80% figure I used. I think he's probably coming from a different way. But you know, accountability is our middle name, and so we are guard pretty carefully, you know, being right.
Well, thank you for your answer. I just want to try to follow up with this at a later date so I don't lose track of this kind of information. I appreciate your comments and yield back the remainder of my time.
I was just looking in a copy of the GAO report where there's a letter from Mr. Gingrich, Chief of Staff, basically saying they have reviewed this report and appreciates the opportunity to comment on their draft report. So VA has seen the draft, correct? Just got it. No, you saw the report. This is talking about the draft.
The draft. Yeah, I'm sure that it was reviewed here. I can't recollect that I saw it, but yes.
You haven't reviewed the draft?
I can't recollect that I did. That doesn't mean I didn't. I just don't know.
If there was a report entitled Weaknesses in Policies and Oversight Governing Medical Supplies and Equipment Pose Risks to Veteran Safety, you wouldn't remember that you saw it?
I might not, no.
I hope you did. I hope you did, or somebody in VA did. Ms. Wilson, you're next. Thank you for joining the committee today.
Thank you, Chairman Miller and Ranking Member Filner. I am new to this, and I inherited this from my predecessor. I'm from Miami, Kendrick Meek. And so my following of this debacle was by reading the Miami Herald. And then my great Congresswoman, Ross Layton, invited me to a tour of the VA hospital and a meeting with the people there, with the administrators there, and then a press conference. And at the meeting, I was really shocked by the cavalier attitude of the administrator of the hospital and the way she was going about answering the questions. First of all, I found out that there were 5 people who contracted HIV/AIDS, 8 hepatitis C patients, and 1 hepatitis B. We're not sure whether it was from the instruments but they have it, and they were tested with the unsterilized instruments. So my question to her was, where are these people now, and what are they doing? And no one at that meeting had an answer. No one could tell us what was happening with these particular patients who were infected. So I asked them to assign one person from the hospital to be in charge of, sort of like a caseworker, to make sure that they were being treated, that they were following up with it, and to get back to us and let us know what was happening. So we got a letter saying that they had followed up with all of them except 4, and they could not find these 4. And they couldn't find, 4 came in for 1 treatment, and then, 2, and then 2 they couldn't find at all. So my concern was that these 2 people, and they didn't identify which 2 they were, they didn't identify which malady they contracted from the hospital, and I'm just wondering, for their safety and the safety of the public, is there any way that we should include the FDLE or the FBI or the local authorities to try to find these people, even private investigators, so that they would know that they are infected and they, in fact, should have the opportunity for treatment? That's the first question. The second question has to do with Ms. Baracall, who is the woman that was in charge of the hospital. It is my understanding when this debacle first occurred, she was reassigned and someone from Jacksonville took her place. Before she was put back into her place at Miami Hospital, there was supposed to have been a report and some sort of evaluation that was supposed to be released before she was sent back to her position. She was sent back to the position. There was no report done. The Miami Herald, through a public records request, asked for this report. And to date, they still don't have it, and she's still there. Are you aware of all of these circumstances at the Miami Veterans Hospital?
I am aware of them, Congresswoman. There was a report, and Ms. Baracall is back at the Miami VA Medical Center. I don't recollect the specifics of what was in the report, but we can certainly resurrect that and see. I would say that I think that Congressman Ross Latham and others would agree that Miami is really beginning to turn around, that the atmosphere and the practices of that hospital are really quite improved over what they were when we originally had the colonoscopy incident several years ago.
My question has to do with finding the patients who are unaccounted for. What can we do to find them from this point?
That's a good question, and I honestly don't know. I know that the medical people follow up. I don't think that they use private investigators, the police or the FBI. That's certainly something that we can look into if we still are not able to contact those last 2 patients. And we will look into that.
Okay.
Thank you, Ms. Wilson. I'd like to use Chairman's prerogative, if I would, and beg the indulgence of the committee members. And since we're dealing with Miami, Ms. Wilson has been talking about, I'd like to go ahead and recognize Chairman Ross Layton, if she would, to continue the questioning regarding Miami.
Well, thank you so much, Mr. Chairman and Mr. Filner. Thank you for your leadership on this issue that has been ongoing and so frustrating for so many of us. And Mr. Undersecretary, you said you're doing better, but you continue to find patients who were not notified in Miami. 12 additional names this past December, you state that. excellent way of notifying industry standards, those kind of phrases. And while I'm happy that the VA is making efforts to reform its procedures in the area of reusable medical equipment and in notifying at-risk patients, we have been down this path before. We are so frustrated, Ms. Wilson, Mr. Rivera, Mr. Diaz-Balart, and I. In 2009, the Miami VA, as you know, notified over 2,400 veterans that they may have been at risk for infectious diseases. Then a year later, during a review of the VA's facility logs, a year later, an additional 79 veterans were discovered to have been at risk. And now, just this past December, where Ms. Wilson was talking about, another 12 names were discovered in a third review. Of these veterans, 17 have been tested positive for HIV, hepatitis B or C. Doesn't mean that it's cause and effect, but it's very alarming. So over these 3 years, the list has kept growing. Members have previously sat in this very committee room, were assured by VA that the administration was taking action to correct this previously failed policies. This has not happened. Those steps have not been put into place. The VA central office initially left it up to the Miami VA to identify at-risk patients, and I would like to ask these questions. Will another review, if we were to do another review, find more at-risk patients? What degree of confidence do we have that every time you've done a review, you've found additional folks who've fallen through the cracks? I don't have confidence that the entire pool of at-risk patients have been identified. Secondly, are there now oversight mechanisms in place at the VA central office where an independent authority will take charge and make certain that a local VA like Miami will meticulously review patient files to identify those who require notification? Or is the attitude of the central office, things are going well, patients are being identified, and all systems go? And number three, so here we are again, members are being told that the VA has taken steps to eliminate the problems from the VA centers, and if additional names are found, or if it's discovered that facilities continue to use improperly sterilized equipment, what then? What steps will be taken? And I share Congresswoman Wilson's frustration when we were there and we've had so many meetings about the follow-up. And I remember the first meeting that we had, and that was with her predecessor, Mr. Meek, and we made this so brilliant suggestion that perhaps they could go door to door and knock on the veteran's home, apartment, wherever the veteran is, and they said, "Oh, that's a good idea," and we're just so brilliant that way, and so they said, "Okay," so they got back to us and they said, "Yes, we've knocked on the doors," and then we kept asking, "Okay, of those you've identified and you've knocked on their doors, have each of these veterans been informed that they can get treatment? Have they turned the treatment down?" And I understand that there are privacy concerns. We're not asking for their names and their addresses, but they cannot tell us. At least they haven't told us. They have not told us, this is the pool, these have been notified, these are under care. We have no degree of confidence that they are in fact getting care. We don't have to force someone to get care, but we're talking about community health problems if these veterans don't get the care. So it's not just that veteran, it impacts the entire community. You can't force them to get care, but you can certainly work with that veteran to have that veteran understand how serious this is, how it can impact the community, and let us know that those veterans are indeed getting care. But I want you to understand how frustrated we are that we have these meetings once and again, and honestly, we're saying this is water, and they'll say, "Oh, okay, this is water," and it's very patronizing to us because we know that they must know more. I pray that they know more than they're telling us. I pray that the veterans are getting the treatment that they're getting, but they're not telling us. So I'd like to say with a degree of confidence to my constituents, this problem really has been worked out after all of these years, and I don't have that confidence, but I thank Ms. Wilson for everything that she's been doing, and Mr. Rivera, Mr. Diaz-Balart. We're all united. We have a very united delegation on this, and I thank the chairman and the ranking member for being such fearless leaders on this. So I'd like to see if you could answer those questions. Are we going to do another review in Miami? Do you have a degree of confidence that every at-risk individual has been identified, that there's been some follow-up care, that everything really is what it should be? And if it turns out that it isn't, what then? Thank you, Mr. Chairman.
Thank you, Congresswoman. I can answer those questions. First, let me start with the last. We can provide you with information, again, not specific names, but about the number of people that have been contacted, the number of people that are under care, and that's available, and we will certainly get that to you. The second thing is when they're notified, part of that notification involves what are the consequences of this potential exposure, and what are the remediation, so that if somebody feels as if this indeed was the cause of their contracting HIV or hepatitis C, they have a legal remedy. And every single person that we notify that's positive is told about that legal remedy. In terms of the...
And let me ask you, when you say that we can get you that, that's the same thing that happens to us when we meet with them. They'll say they can get it to us, as if we were meeting on what to order for lunch. I mean, that is the purpose of our meeting, so that is the information we want, and then after every meeting, they say, we'll get you that info. So that is the purpose of what we want. All of those individuals, without any names, where are they getting care?
We could get that to you within a week. The second question involved the process and how certain am I that we have identified and notified everybody. And I am as certain as I'm going to be that we've done that. We learned a lot in the Miami process. Just to reiterate, initially that was the identification of who should be notified was the responsibility of the facility, and they made a decision to use the computerized medical record and the coding that was in there to identify the people that had colonoscopies. It was found out several months, almost a half a year after that notification, someone called up and said, I had a colonoscopy during that period of time, but I wasn't notified. So there were some errors, if you will, in the coding that occurred that went into the computerized medical record. That was the second iteration. And then the third iteration had to do with a logbook that shouldn't have been there, but was used and had in it, again, 11 patients that weren't on the computer list because those 11 patients had been inappropriately coded when they went into the computer list. But the primary lesson we have learned here is that we have a central office team now that does the process of identifying who should be notified. This event is something that occurs, hopefully, once in the lifetime of a medical center. They have no experience in developing the material that you need to get a list. So we have now made that a central office function. We send a group of people down who have experience doing this and have done this in other circumstances, and they become responsible for developing the list of people that need to be notified.
Thank you. And Mr. Chairman, just one last note. The Miami Herald, Fred Tasker, has been doing an excellent job on this, and I hope that he would not need to file another Freedom of Information Act to get information about these vets. I would hope that you would share information with our community, not names and addresses, but what is new on the status. It's a big concern. What's that? No, he still doesn't have it. Correct, Mr. Tasker.
Thank you, Madam Chairman. Mr. Clay.
Thank you, Mr. Chairman. Thank you for conducting this hearing. Let me personally thank you and Mr. Filner, as well as the committee staff, for giving the time and attention to the issues that have arisen over the last year or more at Cochran VA Hospital in St. Louis in my district. Let me start with Mr. Day or Mr. Williamson. Have the sterilization problems in the dental clinic at John Cochrane Hospital been resolved?
Yes, sir, I believe they have.
Can you start your mic? Thank you. You think they have? Okay, now, what was the final source of the contamination in the surgical unit? What was the cause? Can either one of you speak to that? Or can you, Mr. Petzel?
I think I can. I don't believe, Congressman, that they've had any experience with that. And I assume that you're referring to the fact that there was some discoloration discovered on surgical instruments by one of the scrub nurses, and we then stopped surgery in St. Louis while we tried to discover what that discoloration was. There was not a sterilization problem or an issue. Those instruments were sterile. And eventually, we came to the conclusion that it was a combination of events. The fluid that was used in the pre-wash and the filters on the steam sterilization unit. When the solution was changed and when the filters were changed, we were able to get rid of the discoloration, and that started up again. This is something that we discovered and I think was managed quite well.
Oh, okay, doctor, was that a vendor issue, or was it inside the hospital?
Well, it was inside the hospital insofar as the instruments were being sterilized in the hospital. But again, it had to do apparently to the fluid that was being used and to the filters in the sterilization
Which caused
instrument.
the spots on the instrument.
Which caused spots on the instrument, correct, discolorations, but not an issue of sterilization.
Okay, let me ask you, why does Cochrane VA Medical Center consistently receive a low patient satisfaction when compared to other VA facilities, and why does this problem persist year after year?
It would take a few minutes to
Go right ahead. I
explain
have
this.
a little time here. Go right ahead.
When you look across the country, inside or outside the VA, wherever you have customers, wherever you have patients, the satisfaction of the individual patients with their care is a direct reflection of employee satisfaction. There is a very, very strong relationship. If you have a satisfied workforce that enjoys their job and is doing it with a smile, so to speak, you're going to have, generally speaking, a group of patients that are going to also feel good about their experience. And I think there was a history at John Cochrane, again, before my time, where we had an employee group that was not particularly satisfied or happy in the workplace.
Now, wait a minute. Let me stop you there. It sounds to me as a cultural issue in that facility.
Absolutely.
Have you addressed it, and how?
I believe that we are addressing it. Rima Nelson, the new director there, has created a much more open atmosphere where people can talk to her about problems. She's approachable. She's out walking around that hospital continuously, testing the waters, taking the temperature, seeing how things are happening. When we hear now from the union and from the service organizations that the atmosphere there has changed, that this is a better place to work, a happier place to work. My hope and expectation is that this is going to be reflected in the patient satisfaction score.
When will we know that?
We do every month, we do a series of inpatient and outpatient satisfaction scores. So I'm hoping that relatively soon, I don't know how long.
Okay,
I don't know how long, but I'm hoping relatively soon we will see a change.
Okay, my concern is this, doctor. If we cannot improve conditions, perhaps it is time for the St. Louis region to try perhaps a voucher system for patients to receive medical attention from our two world-class medical facilities that are stone's throw away from the VA Cochrane. If you cannot do the job for these people that deserve it, perhaps we need to look at another system to deliver medical care to them.
My expectation is that we are going to see improved patient satisfaction scores at the John Cochrane.
As soon as you receive it, share that with us.
We absolutely will.
Thank you. Thank you, Mr. Chairman, and I yield back.
Ms. Burkle.
Thank you, Mr. Chairman, and thank you to you and to Ranking Member Mr. Filner for all you're taking the lead on this issue, very important issue. And thank you to our panelists today. I am the chairman of the Subcommittee on Health. I am a registered nurse, and I also am an attorney, and I represented a major teaching hospital for many years. So this is all of very particular interest to me. I think the first thing that concerns me is when we refer our veterans to our healthcare and veteran facilities, that they have some sense of what Dr. Rowe mentioned, trust, and that we're referring them to a system that will take care of them. And at the very least, that care should be what the industry offers. I think you're all familiar with JCAHO. Every hospital hunkers down when the Joint Commission comes in and reviews all of the processes, every system, every process. And they hold the hospital accountable, and everyone prepares for that, and there's that accountability factor. So I guess my first question, Dr. Petzel, is what in the VA system is analogous to the JCAHO reviews that a hospital has to undergo every few years?
Well, Congresswoman, first of all, we do undergo the Joint Commission reviews just like everybody else. So our hospitals are all accredited by the Joint Commission. Number two, the process has changed recently insofar as now you don't know when they're going to come. And what happens is what we call continuous readiness. That is, you have to be ready for them to drop in at any moment. They do not announce that they're coming and they show up at your doorstep on a Monday morning or a Tuesday morning and begin their survey. It's a tremendous improvement from my perspective, because previously we all dropped everything for 6 months before the Joint Commission came and cleaned the floors and uncluttered the hallways and did all those sorts of things. And now you have to do that all the time, which is the way it should be. We also have the SOARS process, which is an internal within VHA process of inspection that occurs. We have the IG does their CAP reviews. Every 3 years they go to every facility and are much more thorough than the Joint Commission in terms of oversight and looking at us. And those are probably our two biggest VA-related internal reviews like the Joint Commission.
Well, then how do situations like these occur with that kind of oversight, with that kind of, what happens that these situations, the VA finds themselves in these situations? Any private hospital would have corrected it, wouldn't happen again, and these instances continue to occur. And if you've got this oversight in place, why aren't corrections being made?
Well, at each one of the medical centers, Congresswoman, that are involved, those corrections have occurred. We don't have a recurrence of any of these incidents at any of the medical centers that were originally, of these 4 that we've been discussing. They have cleaned up their act, they have changed their practices, and they are doing the things that they need to do to appropriately sterilize the equipment. I think that why does this happen in our system? We're a national integrated system. Everybody should be aware of what's going on, and I think, again, there is a failure of leadership. People not holding other people accountable, people not checking to be sure that indeed everybody does have training in the SPD. Indeed, everybody does do their job. You're supposed to watch somebody do their training. And I think when these things break down, it's a failure of those things to happen. It's, again, a failure of leadership.
I would submit that if it's happening in any of the VA hospitals and it hasn't been corrected, we're looking at a system, a hospital system. And so the policies and procedures should apply to all. So if there's a problem here, that correction should take place in all of the hospitals. And apparently that hasn't been done.
And I absolutely agree with you, Congressman. That's absolutely the way this system should work.
Just briefly in my few seconds that I have left, when we look at medical malpractice, the question is always asked, what is the deviation in the standard of care? And that's how we gauge whether or not there's malpractice. What is the standard of care that the VA hospital, what standard of care would you be adhering to? which one standard of care? I hear lots of different oversights, but what is the standard of care you apply?
I'm sorry, Congressman, I don't quite understand the question.
Well, I'm assuming that I assume the VA hospital adheres to one set of processes and one set of procedures based on something. And I'm just, whether it's JCO standards or what, it sounds to me like it's rather arbitrary.
First of all, sort of at the top would be the Joint Commission standards. We are, again, accredited by the Joint Commission. Every one of our 152 medical centers and 871 outpatient clinics have that accreditation. So that would be one standard. Secondly, we have policies and procedures that are much more specific than what the Joint Commission would be looking at for many, many things, and we adhere to those standards. And I think we would not get argument either from Dr. Day or Mr. Williamson about our policies and procedures. We have good policies and procedures that are at the top. The problem is adherence to those policies and procedures. The problem is, are people following those policies and procedures? So I'm not as concerned about the standard that we're setting as I am about, are we adhering to that?
I'm out of time. If I, would the chair just allow one more question?
Very short.
Dr. Day, would you agree with what Dr. Petzel is saying?
Yes, ma'am. I believe, yes, ma'am. I believe VA has really quite excellent policies and procedures that are, in most cases, industry standard and often put together with the use of experts who spend part of their time at VA facilities and part of their time at the various universities. So much of the staff at the VA is a dual-hatted, medical school / plus VA. So I think their policies are correct. As I indicated in my statement, I think the issue is execution. That is doing what you're supposed to do every day.
Thank you, Mr. Chair.
Mr. Turner.
Thank you, Mr. Chairman. I want to thank the chairman and the ranking member for their tenacity on this issue, but I particularly want to thank the chair. Chairman Miller has taken a particular interest in these issues. His care for veterans has been evident throughout his work on this committee, but in these instances where these specific infractions came to light, Chairman Miller has dived in. He came to my community and has personally read all the documents that are involved. And I want you to know that if it hadn't been for Chairman Miller, I don't think my community would even have the information that it has today. The VA has stonewalled my community. They have not been responsive. If it wasn't for this committee beginning to force the VA to work with my community, I honestly believe that we would have even less than we have today. Mr. Petzel, you said this is unquestionably a failure of leadership. Then when you were asked about accountability for that leadership, what happened to those people who would have been that failed leadership, you really didn't know what had happened to the people in this chain. We have in my community a dentist who for almost 2 years violated the standard cares of practices, not sterilizing equipment, taking things from people's mouths, using the same gloves the entire day while working on people, not cleaning instruments and tools that he used on numerous people. And this isn't something that was going on for a couple decades in secret. It was visibly obvious. It was in a clinic that was located directly above the director's office. This wasn't even in an isolated, located facility away on campus. This is something that was known. So when you say failure of leadership, I agree. The dentist in question, though, got to retire. The chief of staff got to retire. The director was promoted. So if it's leadership, if you go up the chain of command where it goes from the patient to the dentist to the chief of staff to the director, no one has been held accountable. So we have a failure of accountability. We also have a failure of being able to complete an investigation. The OIG was unable to talk to the dentist in question because he retired, or the chief of staff, or even the complainants because of people having left the system. So we don't have accountability, and we don't even have the ability to do a complete and total investigation. The review that was undertaken by the VA was pretty much done in secret. The review board that the VA impaneled, and even the testimony that was taken when it was released to the community, the names of all the individuals were redacted. And they were redacted so we wouldn't even know who it was that you were relying on to review what had occurred and advising the VA as to what patients to be notified or even what their care was supposed to be. I contacted the Greater Dayton Hospital Association for my community, your regional peers, and I asked them to review what you did provide the community. They provided a report basically saying, one, that all of the information needs to be released. There's a number of documents that are really critical for our community to understand whether or not you are taking appropriate precautions for those that were subjected to a risk of HIV and for hepatitis. Secondly, they disagree with your scope of the patients that are notified. They believe that many more people were subjected to exposure to HIV and hepatitis. And so they have asked for, in addition to an expansion of the documents that are released, for additional patients to be notified. Now, I appealed your redacting of the documents that were provided to us. I was told that that you wanted to protect those who were part of the review board so they would not be subject to harassment. You know, in our court system, we don't let juries stand behind a screen. We require that they be held accountable to the community for what their decisions are on things that are very, very significant judicially and to people's lives. There is no reason why you should be impaneling review committees that are then done in secret, that we all then have to guess as to what their motives were, their backgrounds, their experience, or the basis for their determination. When I asked for the non-redacted version to be released, you answered that even the dentist's name in question should not be released because of the nature of the investigation and seriousness of the allegation. The dentist could be subject to harassment or worse. You actually indicated that you didn't want to release it because he could be subject to annoyance or harassment. Annoyance or harassment, like being subject to the risk of HIV and hepatitis? I mean, this is incredibly serious, and the VA is not being open with my community, or I think even giving an ability for proper oversight from Congress. I have 3 questions for you. You said this is a failure of leadership. Now we're going to come to the issue of your leadership. Are you willing to expand the number of patients that were notified, tested, and received treatment as a result of the actions that occurred at the Dayton VA? Are you willing to release the documents that were requested by our Greater Dayton Hospital Association so that they can review your investigation into these practices? And are you willing to release the non-redacted review and transcript from your review board so that we can actually evaluate your approach on this issue?
In answer to the first question, we are and will go back and look at the process that we went through in terms of identifying the patients that needed to be notified. At this present time, I stand by the decision that the Clinical Review Board made as to who should be notified, but we are going to look at that. Number 2 is that we've made available to the committee, through the chairman, all of the material that they request. We cannot release some of this material to the Greater Dayton Hospital Association. We cannot release
sir,
that.
Hold on a second. Just if you, I know my time is, but if you permit me, Mr. Chairman, I have the documents of the Freedom of Information Act provisions that you're standing on. They are all discretionary. When I was briefed by your staff in my office, they admitted it was discretionary. So please don't say that you cannot release them, because of course you can. There is no patient information that is being protected here, because no patient information is included in what's been being asked. It's procedures, policies, and actions.
I'm sorry, Congressman, but I have been told by our attorneys that we cannot release to you or to the community those unredacted documents.
Okay, well, then they were in my office, your attorneys, by the way. If you and I meet in my office with your attorneys and your attorneys say that it is discretionary, does that mean you're willing to release them? Because you are not prohibited from releasing them.
If they tell me that they are releasable, then
that it is
we
discretionary.
have to consider that. Beg your pardon?
That it is discretionary within your discretion. You will use that discretion and release them.
I'd have to then consider doing that, but that's not what I've been told.
It is not. You are not required to maintain this redaction, and you you may release these documents. So I would expect that you would use that discretion that you have and release them based upon your testimony today. And then my third question.
Your third
You were
question?
answering on the redaction and the release of the documents? Is it combined both on the issue of redaction and release
Correct.
of the documents? Okay. Thank you. Mr. Chairman, thank you for your work on this.
Thank you, Mr. Turner. Mr. Bilirakis.
Thank you briefly. Thank you, Mr. Chairman. I appreciate it. Question for the panel. Should a person acquire an infectious disease and it's a result of a mistake by the VA health system, what resources are available to that individual besides the legal remedies that you mentioned? Thank you.
That's an excellent question, Congressman. First of all, you can never establish for sure that it was associated with the event or that it wasn't associated with the event. The assumption has to be that if they had a colonoscopy with what was felt to be an unsterilized colonoscope and developed hepatitis C, that was responsible. So we assume the responsibility for anybody that's converted. Two things are fundamentally available. They are eligible for and will receive health care from us for as long as they need it for the rest of their lives, if that may be the case. Two is that they have a legal remedy insofar as they can file what we call a tort claim and recover damages if the court indeed believes that there is a relationship between our event and their disease. So health care on the one hand, compensation on the other.
Does it require filing a lawsuit to receive any sort of compensation?
Yeah, in most instances, yes. But let me ask one of the people here with me. I think that we may be able to service connect somebody who develops a disease because of something we did. Is that correct? They believe so. Let me get back to you specifically about that.
Okay, please do.
I will.
Thank you. I yield back, Mr. Chairman. Thank you.
Mr. Filner?
Let me just go back to my original statement, Dr. Petzel. Again, you have said over and over again there's been a failure of leadership. And yet, again, as far as we know, whether it's civil service protections or whatever, I think it's more bureaucratic defensiveness and secrecy. We don't know that there has been accountability. I think we need to work with you and your lawyers to develop a new way to give us some assurance that this stuff is being handled. What you have given us today gives us very little confidence that these personnel decisions are being handled in a way. You gave us 3 examples of something happening, mainly retirements, or I forget what you called them, forced, you said something. Anyway, 3 for all these years of problems. Whether we can sit in executive session as a committee and talk to you about that, I don't know. I think we have to examine that, Mr. Chairman. I think you should examine it. We need a new process here because you're standing on civil service stuff, you're standing on secrecy, you're standing on legal stuff, and yet I don't care what the private sector does. This is a public institution. We have to get trust and confidence in a different way. And the same legal remedies are not available to someone with regard to a public system anyway. But I think we need to have a discussion about how we do this. This is very, very unsatisfying. And if you could tell us more and we could get more in a situation, whether it's the chair and the ranking member, whether it's the chair of the subcommittees, whether it's the whole committee in executive session, I don't know. But we got to figure out a way to get a better handle on this stuff because our constituents, we can't tell them anything because we don't know anything. And even if we knew something that says, yeah, you have to have confidence, it's been taken care of. I can't say that to anybody. So you need to find a way to give us the confidence to give our constituents, and we'd be happy to work with you. I mean, we need a new way to do this, and it's just not working the way it is. Thank you, Mr. Chairman.
Thank you very much. Are there any other questions of the committee? I thank the panel for being here today. There probably will be some questions that will be sent for the record. We thank you for your testimony. Thank you. If the second panel will begin coming forward, we have two more witnesses here to be with us today. Dr. Michael Bell.
I know.
He is the Deputy Director of the Division of Healthcare Quality Promotion for the Centers for Disease Control and Prevention.
I'll be right back.
And Mr. Anthony Watson, Director of the Office of Device Evaluation of the Centers for Devices and Radiological Health for the Food and Drug Administration. We thank you both for sitting through the testimony from the first panel and the questions. We thank you for being here today. As you have witnessed, the patient safety incidents at VA medical centers are complex and have wide-ranging implications. I look forward to hearing from you today on how we can take a comprehensive, proactive approach to patient safety for our veteran heroes and for all Americans. So with that, Dr. Bell, you are recognized for 5 minutes.
Good afternoon, Chairman Miller, Ranking Member Filner, and other distinguished members of the committee. I'm Dr. Michael Bell, Deputy Director of the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention. Thank you for this opportunity to discuss the important topics of preventing healthcare-associated infections and ensuring safe healthcare nationwide. Healthcare-associated infections are infections that patients get while receiving medical care. These infections range from those related to highly specialized intensive care procedures down to infections caused by lapses in the most basic safe practices, for example, reusing disposable syringes. CDC estimates that roughly 1 out of 20 hospital patients has a healthcare-associated infection. These infections are often severe and can kill people, and in hospitals alone, they result in an estimated $26 to $33 billion a year in excess costs. Fortunately, we know how to protect patients from many of these infections, and if we can protect them, then we must protect them. Healthcare-associated infections can occur in any healthcare setting. These settings include hospitals, dialysis centers, ambulatory surgical centers, and nursing homes. Medical care that used to take place only in hospitals is now increasingly being delivered in non-hospital settings. As that shift occurs, we're seeing a growing number of outbreaks in those settings. These are settings where infection control programs and oversight are generally less rigorous compared to hospitals. Today, I'll focus my remarks on healthcare-associated infections that happen because of lapses in basic infection control. Infection control refers to the established collection of rules and procedures designed to prevent the spread of infection during healthcare, including basic safe practices such as not reusing syringes or appropriately sterilizing or disinfecting equipment. Lapses in those basic safe practices are entirely unacceptable. These are never events. Unfortunately, we continue to see egregious errors that have resulted in transmission of serious infections. As a result, CDC is working in a number of ways to evaluate the problem and launch prevention strategies to stop these lapses from occurring. CDC has worked with state and local health departments across the country and identified numerous lapses in basic infection control over the past several years. Recent examples include using the same syringe for more than one patient, accessing a shared vial of medication with a used syringe, using contaminated equipment for diabetic testing, inadequately cleaning and disinfecting medical equipment, such as endoscopes, and improperly reusing medical devices like biopsy needle guides. Such practices are simply unacceptable. Unfortunately, they're happening across the spectrum of healthcare, particularly in non-hospital settings. More must be done to ensure that correct infection control practices are maintained wherever medical care is delivered. CDC is actively engaged in eliminating these events. Our current efforts include developing national infection control guidelines and working with CMS to ensure that they're followed, developing checklists for state and CMS surveyors to evaluate facilities' infection control practices, responding to outbreaks and emerging patient safety threats, educating healthcare personnel and patients about basic infection control requirements, and promoting the development of safer medical devices. Our ultimate goal is to ensure that all patients receive safe care in every healthcare setting. We use CMS oversight and payment policies to drive adherence to CDC's infection control guidelines. However, when there is a lapse in infection control, patients must be protected from harm. Local and state authorities are used to halt the unsafe medical practice. It is then necessary to identify which individuals were exposed and to promptly notify them so that they can receive appropriate care. Sadly, in the past 10 years, over 100,000 patients have had to be notified that they were exposed to an infection control lapse related to unsafe injections. Even more patients have been exposed to other errors, such as improper sterilization of equipment. Ensuring appropriate infection control in all healthcare settings is a CDC priority. Our public health system is crucial to ensuring safe care for patients, providing a unified approach to implementing infection control, monitoring safety, investigating and controlling outbreaks, providing oversight and education, and researching new ways to improve healthcare quality. As we work toward elimination of all healthcare-associated infections, ongoing vigilance is needed as new healthcare settings and changing technologies create new challenges to healthcare safety. CDC continues to address those challenges, working to ensure that our patients are safe in every healthcare setting. We know how to protect patients from these infections. They can and must be prevented. Thank you for this opportunity to testify. I'm happy to take any questions you might have.
Thank you very much, Doctor. Mr. Watson, you're recognized.
Mr. Chairman, Ranking Member Filner, and members of the committee, thank you for the opportunity to discuss reprocessing of reusable medical devices and the importance of adequate reprocessing to protect patient safety. Today, I will discuss the challenges to ensuring the safety of reprocessed medical devices and describe actions FDA is taking to address those challenges. Reusable medical devices are devices that are designed and labeled for use on multiple patients and are made of materials that can withstand repeated reprocessing, including manual brushing and the use of chemicals. Some examples of reusable medical devices are surgical instruments, such as clamps and forceps, endoscopes used to visualize areas inside the body, and accessories to endoscopes, such as arthroscopic shavers and laparoscopic surgery accessories, such as graspers and scissors. All reusable medical devices can be grouped into one of three categories according to the degree of risk of infection associated with their use: critical devices, such as surgical forceps; semi-critical devices, such as endoscopes; and non-critical devices, such as stethoscopes. Adequate reprocessing of reusable medical devices is a critically important step in protecting patient safety. Reprocessing is intended to remove blood, tissue, and other debris to ensure that devices are safe for the next patient use. Reprocessing can be both labor-intensive and time-consuming because most reusable medical devices require a specific reprocessing regimen. In general, reprocessing reusable medical devices involves three steps: initial cleaning, which is at the point of use; transfer to the reprocessing work area where the device is thoroughly cleaned; and disinfection or sterilization, depending on the intended use of the device. Its risk of infection transmission and the materials from which it is made as well. The device is then stored or routed back into use. Many factors contribute to reprocessing difficulties, including device complexity, absence of best practices, user error, and poor instructions on how to reprocess. Manufacturers, healthcare facilities, healthcare professionals, and FDA share responsibility for reducing the risk of healthcare-associated infections, or HAIs, from inadequately reprocessed reusable medical devices. HAIs are infections caused by a wide variety of common and unusual bacteria, fungi, and viruses during the course of receiving medical care. Under FDA labeling regulations, a device must have adequate directions for use. This includes instructions on how to clean and disinfect or sterilize a reusable device to ensure that it is effectively prepared for its clinical use. FDA applies its unique position and expertise to reduce the risk of infection from reusable medical devices by evaluating devices prior to marketing, identifying device designs that facilitate proper reprocessing, assuring that manufacturer instructions are clear, and promoting collaboration among all stakeholders. FDA also works with manufacturers to correct product problems associated with reprocessed medical devices. FDA expects manufacturers to design their devices to minimize debris retention, provide complete and easy-to-understand reprocessing instructions, and validate their reprocessing protocols using clinically relevant soil. Healthcare institutions should periodically assess infection control practices in clinical areas, ensure that those responsible for reprocessing understand the importance of the job and are given the necessary training to perform it properly. Reprocessing staff should ensure the distinct and separate steps of reprocessing they should understand the distinct and separate steps of reprocessing, and they should follow reprocessing instructions provided by device manufacturers. Physicians and nurses should consider that reprocessing plays a role in device performance and follow up with the appropriate chain of accountability, such as reporting adverse events that may be related to inadequate reprocessing following guidelines established by professional societies, and communicating with manufacturers regarding labeling issues and ease of reprocessing. While FDA believes that the risk of acquiring an HIA from a reusable device is relatively low and that the benefits of these important devices outweigh their risks, we are taking a collaborative approach toward improving the reprocessing of reusable medical devices. On April 29, 2011, FDA launched the Reusable Medical Devices Improvement Initiative to reduce the risk of HIAs from inadequately reprocessed medical devices. FDA's approach to addressing reprocessing problems focuses on collaborating with other government agencies, manufacturers, healthcare facilities, and healthcare professionals to strengthen all steps in reusable device reprocessing by fostering improved, innovative device designs to reduce debris retention, strengthening the science of cleaning and high-level disinfection or sterilization of medical devices, and ensuring that healthcare facilities properly perform cleaning, disinfecting, and sterilization. Specifically, FDA has issued revised draft guidance that updates and clarifies the recommended content of and review procedures for medical device applications concerning the labeling instructions for reprocessing reusable medical devices. In addition, this draft document provides more detail about FDA's recommendation for the validation of processes intended to support reprocessing. We've also announced a public meeting to be held on June 8th through 9th to bring together key stakeholders, including industry, user facilities, standards organizations, healthcare accreditation organizations, government agencies, and professional societies. This is the first in a series of conversations between FDA and reusable medical device stakeholders to discuss factors affecting the reprocessing of reusable medical devices and FDA's plans to address the identified issues. Finally, FDA has developed a webpage that provides general outreach about reprocessing of reusable medical devices to educate consumers and healthcare professionals. Reducing the risk of infection from reusable medical devices is critical to protecting patients and is a shared responsibility. By using its unique vantage point, FDA is helping to address current problems with reprocessed devices while facilitating improvements in innovative design in the next generation of these devices. Mr. Chairman, this concludes my formal statement. I will be happy to address any questions you may have.
Thank you very much, Mr. Watson. Is it safe for me to assume that VA's been invited to your June workshop?
Absolutely.
Thank you. Do you see a need for research into technologies to develop indicators of some type to improve the ability to monitor the quality of reprocessing of reusable medical equipment?
We have introduced one of the elements of our initiative yesterday was a draft guidance. I apologize, that was actually Friday. Was a draft guidance. That draft guidance contains information on method validation and labeling for these devices. In that guidance, we talk about the science of reprocessing. We get into the steps for reprocessing. We talk about different methods of validation. And by doing that, we hope that those folks will be able to take that information and use it to improve their processes. So our role, we see, is to help facilitate that communication, to help ensure that the right information is out there for the devices, and as well to help the manufacturers produce excellent labeling so that people can understand what they're actually trying to do in the reprocessing area. Specifically, we've also included information in there that includes a human factors evaluation where the people actually have to use the labeling to determine whether the actual users can actually use that device properly and reprocess it properly. So our role, we see, is to help facilitate that communication. That's what the workshop is about on June 8th and 9th.
And I'd like to ask one question for both of you to answer, but Mr. Watson, if you'd answer it first. What lessons are to be learned from VA's experience with large-scale adverse event disclosures?
Well, I think what we've observed from the VA is not uncommon, as some other members of the committee have mentioned earlier. It's not uncommon in other areas. So what we've learned is that we need to improve the labeling of these devices to make sure that people can use them properly. And again, I will say that by doing so, we can help people do a better job of actually reprocessing these devices. The communication that we'd like to have in the June 8th and 9th workshop will also allow us to get their perspectives. By the way, that guidance that we put out is a draft, so we're asking for comments back on that. We're hoping that we can get some more communication in that workshop from all stakeholders. We have not only the VA, we have other healthcare organizations arriving. We have accreditation organizations like JACO, for example. The commission is going to be there. We're also hoping that users and medical device manufacturers will be there so that they can have a dialogue on the actual ground level problems that they're seeing. And by doing so, we can help those manufacturers come up with better device designs, for example. Some of the device designs that are out there right now don't facilitate reprocessing. They might have narrow lumens that make it difficult to clean. They might have hinges. They might have rough surfaces on the inner lumens that collect debris. So we're hoping that by having this dialogue, we can lay the groundwork for future device designs to come out that will help facilitate those folks in the hospitals from to do a better job.
Dr. Bell?
Unfortunately, I think one of the most striking things related to what we've heard about today is that it's not unique to the VA system. It's emblematic of healthcare in the United States. We're seeing lapses in basic practices across the country and in Canada as well. This is something that needs to be tackled systematically. I think that the benefits of being able to work through something like this include having an opportunity to deliver better products to the users. We've been able to take our long-standing guidelines. This is nothing new in terms of science, but those guidelines are now packaged in handy tools for CMS surveyors to use when they actually look at facilities. The same things are being used by the Joint Commission. It's striking to me that a facility that was shut down in Nevada a couple years ago was shut down 3 months after it passed with flying colors from a local inspection. The problem there is that they're inspecting many of the wrong things. They're looking at fire extinguishers and hallway widths, all of which are fine, but they're not looking at some of the critical issues about injection safety and other safe medical practices. Being able to translate our guidelines into useful tools to put into the hands of the surveyors is one way that we're making use of these unfortunate examples. Being able to build the guidelines into CMS payment policies so that at a broader level we're able to enforce adoption of these guidelines with fiscal authorities. That's a second way that we're seeing some benefit here. With regard to the notification issue, we were asked for input from the VA, and we provided that. Related to that, we also were able to do some consumer outreach and find out what people really wanted to hear about and how they wanted to hear it. That's something that we've published on now. And then lastly, we convened an ethics group to understand all of the ramifications of notification, including, when is the notification something that could be harmful, and how do you get around that harm to ensure transparency?
Thank you, Mr. Filner.
Thank you for your testimony today. But for the record, I would like to note that Secretary Petzel and his staff are all in the room. Thank you for being here. I was always frustrated when the VA folks would testify and walk out and never listen to the other testimony. So thank you for being here and listening to that. My sense, I assume you were here for the early testimony. My sense was, and tell me if I'm right or wrong, but the issues, at least that we were dealing with here today, are not primarily those of either the science or the procedures. That is, we have the procedures, and Dr. Petzel explained 9 levels or something of oversight to make sure that, we would have them. And when mistakes occur, and they're always going to occur, we get those new policies in place. So that's not my sense of where the problem is. My sense is still in the, the accountability and the way we handle. As again, we're a public institution. You got to handle things probably in a different way than the private sector, and how we notify not only the patients but the public at large and stakeholders and everybody. So I think. Now, I don't know what your sense is, that because in all these cases that we heard, and I've been to most of the hospitals, the problem was the people, and whether they were implementing what are good policies or not, or whether they were covering up, or whether the communications person didn't know how to notify anybody or whatever. I mean, those became the problems, because I think the public understands that mistakes are going to be made. They just want to have honesty about it. What's my risk? What do I got to do? How do I treat it? And let's just get on with it. Not, that mistakes won't get made. I don't know what your sense is, if you guys want to comment on that. I'm harping on the accountability because I think that's where the problem is.
Well, if I may, I will say that what you're describing is an important transformation into a culture of safety. This is something that is important across the healthcare system in this country. There was a time when infection prevention was presumed to be the job of an infection control nurse, and that individual would take care of it. In fact, it's everybody's job. Anybody who has any contact with a patient is responsible to ensure that individual's safety. And having that be understood throughout a healthcare system is one of the major goals and challenges that we face right now. When you talk about accountability hand in hand with transparency, we want a system where any individual can stop a process cold and say, no, what I just saw was a mistake, we've got to stop that. We've seen that work. Shortly after the public was notified in the newspaper of syringe reuse mistakes, there was a secretary in a clinician's office who watched the physician start to reuse a syringe and say, I just read that that's wrong. We have to stop doing that, and by the way, we should notify the health department. So that kind of culture of accountability and safety is something that I think that needs to increase throughout our healthcare system.
I'd like to add to that if I could. So I'd like to echo Dr. Bell's comments, and I would like to say that it's not only an issue of not being able to communicate properly or lack of leadership. It is, in fact, unfortunately, a lack of also knowledge and understanding of the process and the procedures. There is some science, the science is well known, but not to everybody. So I think there is some element of understanding the importance of what needs to be done as well. And for our part, what we've been trying to do is help propagate that message of the importance of doing the right thing all the time and ensuring that the folks that are going to be responsible for cleaning these devices actually have something that they can actually clean to reduce the complexity. Hopefully, we heard from Dr. Pretzel that they were reducing the number of devices in their hospital, that all the people would have to learn how to reprocess. That's a very important step. That is one of the things that we talk about also is reducing the complexity of the reprocessing system. So I think it's more than just goes to leadership. It actually goes to fixing the system, making sure that we can all communicate properly and that we all take our responsibility for the links that we put in the chain to correct the system. And that's what we're trying to do right now. And I believe, from what I've heard, that is also what VA and CDC have done. And we've had communication for various topics, not just this issue, where we are trying to close the loop on that.
Thank you very much. Thank you, Mr. Chairman.
Bill Rackus. Ms. Burkle.
Thank you, Mr. Chairman. Thank you both for being here today. Just a question to Dr. Bell. What guidance do you think the CDC could provide for risk management?
By risk management in terms of preventing these problems?
Yes.
We've actually just produced a consolidated document that takes all of the existing guidelines, which admittedly are substantial, and condenses them down for the use of ambulatory care settings where many of these errors are occurring. That's now up on the website and is a nice 12-page synopsis of the minimum expected standards for safe practices. I think we're recognizing increasingly that having a large scientific document sitting on a website is not good enough, and that we need to produce easy, simple, straightforward things. We're also partnering with organizations like the Safe Injection Practices Coalition to produce useful graphic materials and trifold pamphlets and so on, posters, that individuals can use at the site of care as reminders for care providers. So I think there are many ways that we can reduce risk by pushing the information. As Mr. Watson said, it's not a lack of information, it's that the people doing the practices don't always have it.
And just if either one of you know the answer to this question, what percentage of instruments that are used on an ordinary basis in a hospital are disposable versus reusable?
I don't have that information. We can try to go back and find that out, though, if you would like.
That would be helpful. And as a follow-up to that, of those that are reusable, which ones pose the most significant problems, and what are the ones? Obviously, not all reusable instruments probably have the same occurrence as with complications. So if there's any way to find out which are the ones most responsible for these problems, that would be helpful as well.
Well, if I may, we are actually doing that research to get that information, because one of the things we want to do is be able to help manufacturers understand which of their devices are most at risk. But we do know some of the device design issues that play into that, and I kind of mentioned some of those earlier. Narrow lumens, devices that have rough surfaces on the inside that retain debris. If that debris happens to dry out, they don't clean it properly, and it happens to dry out, it's very difficult to get out at a later date, and it might actually still be there further down the line. Devices that have attachments to them, they collect debris. And sometimes there are issues with chemicals and material compatibility also. So we are actually studying device designs that we know are problematic, and in fact, we've partnered with the University of Michigan, and they're doing a two-phase study for us. They're actually looking at device designs that might cause problems, and there's some interesting information coming back on that. And they're also looking at reprocessing instructions. That's the next phase. At very specific devices, looking at the reprocessing instructions to see if those reprocessing instructions make sense and they can actually be followed. So we will hopefully have more information on that at a later date, but we are looking at that right now.
Very good. Thank you very much. I yield back my time.
Thank you very much. Any other further questions? If not, we thank you. We do have some follow-up questions for the record that the committee, all members will have 5 legislative days to revise and extend their remarks and submit questions for the record if desired. Thank you very much for being here. We thank VA for being here today. We have votes coming up in just a moment, so if there being no further business, this committee meeting is adjourned.